In Calcutta, Cardiology Society of India (CSI) made a presentation on Marfan syndrome, and I think I would share with you so that you can also benefit from it. And again, I suggesting the good idea to subscribe so that you would be notified as and when I put a new video or a new talk. I start with a case. This case is a tall fellow who complains of on and off palpitations, and if you see on a echo, there is a mild mitral regurgitation. There is a mitral valve prolapse. In here, you can see both AML and PML are prolapsing, and that's something like A1, A2, and P2 scallops. And then what you see here is dilatation of aorta, and on measurement it does take more than 4 centimeter in diameter, which is actually the definition for dilatation of aorta. Taking the same case further, and now you notice here there is a mitral valve A2 and P2 scallops prolapse, and then you see here this is a mitral annular disjunction, and you also notice in a subsequent 3D echo this is the mitral annular disjunction. I've described mitral annular disjunction in one of my videos, and you can follow that. This is the Pickel-Hobbe sign when you have an S wave which is very prominent, and then you have both AML and PML, A2 and P2 prolapse into the left ventricle and left atrium during systole, and that's 3D echo. You can then there are features. Very first thing, we need to start the skeletal features of Marfan syndrome, and in this diagram you can see the most important things right depicted on the top, and this is a genetic association of a FBN1 gene mutation, and the most important parameters of Marfan are dilatation of aortic root and the ectopia lentis. Other features include mitral valve prolapse, like we had it in our case, a tall build and pneumothorax, and there are other features, skeletal features, which help us make a diagnosis of Marfan syndrome, and pectum carnatum, pectum excavatum, and signs of the hand and the wrist and the scoliosis. Glaring characteristic of Marfan syndrome is the arm length is more than the height, and that's one of the parameters to take into consideration. And there is a joint flexibility, hyperextendability, and there is a laxity of the skin. So these are skeletal parameters of Marfan syndrome. But does this happen only to Marfan syndrome? No, they don't. There are many congenital conditions which actually can have a similar kind of skeletal or systemic features, and we then put them all together into a category called Marfanoid features. So what are the Marfanoid features? Is all the skeletal features, tall build, hyperextensibility, and there is the skin laxity. And these can happen in many conditions like homocystinuria, you have Ehlers-Danlos syndrome, you have Lewis-Dice syndrome, many more. So we need to differentiate, is it one of these syndromes or is it Marfan? One of the recently published data showed that the patient, those who were sent and referred for a suspicion of Marfan syndrome, about 100 of them had Marfan, and equal a little more number had Marfanoid features only and did not actually confirm that this is Marfan. So we actually went at the later data suggests that these are the features which we thought that are related with Marfan syndrome, but these are not very specific. On statistical analysis, we did not find these features differentiating Marfan syndrome from other Marfanoid kind of conditions. Right? So these were not really very helpful in making a diagnosis of Marfan, and what were helpful were these 5 red flags. Pectum carnatum was associated, you have high arch palate or Gothic palate, it goes as an arch. The middle portion actually goes as an arch. It's more of a triangular one rather than a circular in a normal person. Lens dislocation is quite particular for Marfan syndrome because there is loss of support of the lens because of the fibril absence, and then there are hind foot abnormalities, reduced elbow extension. These features were quite characteristic of differentiating Marfanoid features from Marfan syndrome. Now, we have Gant's criteria which were revised in 2010, and if you use this criteria, it would be very easy for you to actually make a clinical assessment of Marfan syndrome. And what are the criteria are? These are the major criteria which say that if you have a dilated aorta and you have ectopia lentis, diagnosis is Marfan. If you have dilated aorta and you say that there is a gene, FBN1 gene present on a chromosome 15, and in case you find this gene, then it's Marfan. Dilated aorta plus body habitus, and the score should be 7, which I had described in the subsequent slide, or ectopia lentis and the gene. So, you have to have 2 of these major things to make a certain diagnosis of Marfan syndrome. Let's say if we have a family history, previous one was without family history. Now, if we have a family history, then things are little easier. You have to have only dilated aorta or ectopia lentis or body habitus score more than 7, then the diagnosis of Marfan is done. In the criteria, this is systemic score. Systemic score, we have given 3 to certain systemic features. The wrist sign and hyperextensibility of joint is scored as given a 3 marks, and then these are the features of scoliosis, pectum carnatum are given the sign 2, and then you have myopia, the length is more, arm length is more, mitral valve prolapse. These are given a score of 1. You add up these scores in the particular patient, and if it is more than 7 out of 20, we have made the diagnosis that there are systemic features, and these systemic features have to be added up. In case you have a family history of Marfan syndrome, if you have a body score of 7 plus, the diagnosis is Marfan. If you don't have a family history, then even score of 7 is not enough to make a certain diagnosis of Marfan. You either have to have dilated aorta or ectopia lentis or the FBN1 gene present to make a certain diagnosis of Marfan. I hope I made things simplified and clear to you. Because there are other diseases which needs to be differentiated from Marfan. One of those is Lewis-Dietz syndrome. In this, the dissection of aorta happens very frequently and very early. The features are dilated aortic root like we would get in Marfan. This happens because of abnormality of the gene in chromosome 9, and the differentiating feature or characteristic features of this are craniostosis, then cleft palate, and you have a cleft uvula. So, these are the kind of salient features of Lewis-Dietz syndrome. Then you have Ehlers-Danlos syndrome, which are there are 5-6 varieties of Ehlers-Danlos syndrome, and the vascular variety is because of the microdeletion and mutation, and the characteristic feature here is a thin skin and lot of vascular issues which can be seen even in the skin or the you have it in the retina or cornea. Certain features and diseases which can have dilated aortic root. Once you do an echo, you find a aortic root dilatation, or what you say is aortoannular ectasia. In these conditions, there are number of causes for that. Once you made a diagnosis of dilated aortic root, then you kind of try to find out whether it fits in one of the disorders that described in this chart. The issue is not the syndrome or something else. The problem is they don't live normal life. And what limits their life to about 40 years on an average is the dissection of aorta and aortic root dilatation. So all these features of Marfanoid syndrome or other disorders which produce skeletal abnormalities like this, we need to look at the aorta because that is the thing which is going to limit their lifespan. So let's focus on aorta. Now we can get an aortic root dilatation. Marfan syndrome particularly affects the sinuses of Valsalva and an ascending aorta, while other disorders affect peripheral aorta and even peripheral arteries as well. Now, this is the case of dilated aortic root. You can see that the aortic root is markedly dilated, and you see very severe aortic regurgitation, and that's happening because of the aortic annulus is dilated, and you can actually see a non-coapting valve, and you can see it on a 3D. There is a hole left. This is the valve is not been able to co-opt well because of dilated aortic root. And that's very interesting. On a 4-chamber color Doppler, you see in the descending aorta down there the to and flow color, right? You can see that, and on an M mode here you can see on the descending aorta there is a reversal of flow. So this indicates the aortic regurgitation is severe. So again, aortic root dilatation and aortic regurgitation are not really cause of concern. The sudden cardiac issues are dissection of aorta. So the dissection of aorta is something which is very, very important to look for, predict, and that's why we follow these patients. And what do we do? And even senior persons like Dr. William Osler were really, concerned about dilated aortic roots. For you, there are very good resource available. That is a recent guideline by ACC and AHA on the aortic diseases. And if you may ask, what is the convention of saying the aneurysm anywhere in the artery? It's a cerebral artery, or you talking about peripheral aorta, or you talking of subclavian artery, anywhere. When you say that there is an aneurysm, by definition, aneurysm should be 1.5 times the expected diameter of that particular artery. But this is not true in case of ascending aorta diameter. Here 3.5, if we say the normal is 3.5 and multiplied by 1.5, it goes beyond 5 centimeter to say this is aneurysm. And if we wait till that time, the chances of rupture of aortic root is very, very high, particularly in disorders like Lewis-Diaz syndrome. So then we looked at when these people tend to develop dissection of aorta, and what are the risk factors, and at what size we should expect that aortic dissection has a very high likelihood. If the aorta dilates more than 4 centimeter diameter, then there is about 90 times more chance of from dissection from the baseline of 1. But the issue is even this 90 times increase, the absolute number is still lower than 2%. So if the absolute number is less than 2%, that is what is the mortality of changing the aortic root and subsequent morbidity. So we wait. What time till we wait? We wait till the aortic root diameter is more than 4.5, when there is about 6,000 times increase in relative risk of aortic dissection. Then based on all the data what we collected, we have given guidelines that when should we actually treat these patients for preventing aortic dissection, that is by a prophylactic aortic root change. one of them, the Marfan Syndrome, if the diameter is more than 5 centimeter, that's an indication for doing a prophylactic aortic root surgery. But there are certain risk factor in case you have in Marfan syndrome, then the limit is little lower, that is 4.5 centimeter. In Lewis-Diaz syndrome and other many congenital problems, genetic issues, we call them as genetic cardiac, the aortic root involvement, and these are the limits are lower than that of Marfan. And as I suggested here, Marfan syndrome with the risk factors, the surgery should be done little early. What are those risk factors? In case you have a family history of dissection of aorta, there is a diffuse aortic enlargement right from there till the arch of aorta, and there is a prior type B dissection in the descending aorta, or there is a rapid growth that is about a 0.5 centimeter per year over the follow-up, then at 4.5 you should actually do a prophylactic surgery, and depends upon the body surface area and gender and the requirement of, in case you are doing any other cardiac surgery for aortic regurgitation, it might as well replace the aortic root as also. So now you understood the measurement of ascending aorta is becoming important. What do we have in guidelines? How should we take a measurement of ascending aorta? We have to take it in diastole, and once we take it in diastole, we take it a leading edge to leading edge, because the other modality are using inner edge to inner edge. In the past, we went back to inner edge and inner edge for taking a measurement of aorta, but now we've recognized that most of the studies in the past, what we did was from leading edge to leading edge, and we should follow this because that is what correlates better with the CMR and CT angio. And what is inner edge to inner edge? That's the inner edge. Let's say if the aortic wall is this thick and you take from the inner edge to the inner edge measurement, that is inner edge measurement. And if you take from a leading edge to the leading edge here, and that adds about 1 to 2 millimeter in that measurement, and that I think is now the current guidelines. We need to take many measurements for aortic root dilatation, and we are kind of limited in case the patient has pectum excavatum or carnatum or crowding of the ribs. We may not get a good echo window and the measurement may not be accurate. Then we have to resort to other techniques of measurement, which includes CT angio and MRI, which would be able to give you the diameters as various places of aorta where our echocardiography does not reach well. We keep it in mind that aortic root keeps on enlarging with age, and it does is more with the body surface area, and that I think we need to make some corrections for body surface area as well as gender when we are considering aortic root diameters. The very important and a good resource for this is the Marfan Foundation. It's a good idea. You can log into that sometimes or download their app, and then it gives you criteria, that is Jant's criteria. It gives you a calculator. It gives you a z-scores of aorta, because as I told you, the aorta root changes with body surface area and age. You have to have a z-score for children. You can have a z-score for aorta. You give body surface area, you give aortic diameter, and then it gives you a z-score. If z-score is more than 2, it's a dilated aorta. And then it gives you hints about genetic, how to do it, gives about differential diagnosis, and these resources are wonderful. And these are the things available, and we also have other parameters for aortic root dilatation. One of those is a body surface area, and second one is aortic root divided by height. And this has not been found to be very, very useful. The third one is once you are doing a CT or MRI, you can take a circumference of that or aortic area. If you take an aortic root area and then divided by height, if it is more than 10 centimeter square per meter, it's again an indication of dilatation of aorta. So there are various ways you can actually measure and calculate aortic root. Fine. So how do we follow up if I find a patient with a dilated aortic root, say it's more than 3.5, which is a normal. I don't call it dilated till it is more than 4, but how do I follow these patients? If I find anybody aortic root more than 3.5, I would wish and suggest echocardiography every year in case you have a syndromic dilated aortic root like in Marfan syndrome. And if it crosses more than 4.5, I become more vigilant and I would suggest echocardiography every 6 months. It's mandatory to have CT or MRI once at least in patients of suspected Marfan syndrome so that you know the entire aortic tree and dimensions everywhere where echocardiography is not very, very good. And then in case our echocardiography isn't good on aorta, ascending aorta, the echo window is not adequate or some other issues, you can follow up the same with CT or MRI every year. So once the surgery is done, then how do I follow? In these patients, I'm looking at two things. I'm looking at if there's a Bantal done, then I'm looking at the aortic valve regularly. I would have to do an echo every year. Not only that, I would be interested in dilatation elsewhere because I have corrected the ascending aorta, but there could be dissection elsewhere. So then CT or MR every 2 years would be a good idea to look for other areas of dilatation. About the therapy, we've been using beta blockers for, and in particular, people have used atenolol for preventing dilatation of aortic root. Let me give you a bit of pathology so that I can tell you to add another drug. Let's say what happens in Marfan syndrome is that there is the loss of a fibril from this media. The muscles are actually held by this fibril, and this is gives you a strength to the aorta. And then this is the normal fibril in a green zigzag lines, and there is a loss of fibril in the Marfan aortas, and then you have lot of oxygen-free radicals shown in red, and that probably indicates an inflammatory process. Also, these two put together put a person at a risk of losing a tensile strength of aorta and leading on to dissection of aorta. And what happens is that this is FBN mutation, and this is an autosomal dominant. About 30% of patients would have a de novo a mutation, and which is not genetically inherited. 70% it is genetically inherited and as an autosomal dominant mode of transmission, and these fibrils are kind of irregular, sparse, they don't make good bonds together, and put together loss of fibril would cause the loss of strength of the aortic wall as well as loss of strength where the lens is held, and that's the reason why there is a dislocation. The clinical features of how patient is going to progress into dissection actually depends upon many ways this fibril gene is representing in various tissues. We have recognized more than 1500, more than 1800 mutations of FBN1 gene, and that's very, very difficult, challenging to pick up. And we still know that we have 10% patients, those who have typical Marfan syndrome. We made a diagnosis based on our criteria, but they do not have this FBN mutation. So we still have to learn more about this disorder. One thing very interesting we learned about this: you have tall person, how can you have that with the FBN gene? Because that loss of the fibril or elastin tissue. So it does not explain long, thin, slender fingers. It does not explain a tall person. It does not explain increased arm span. Then what is happening? Meaning that there is some other association with this fibril gene which is important, and we've now recognized that is TGF beta molecule, which is very, very important, which is closely held by fibril molecules put together, and in case we lose this from here, it gets attached to another pathway, and this pathway leads to what? Excessive collagen secretion and a lot of other inflammatory products. And this is the reason that the single gene FBN1 gene actually leads to the other issues in the body, and this can be corrected by ARB, particularly losartan. And there is one study which was done on losartan in mice, and what they did was they used this losartan to prevent dilatation of aorta, and you can see in placebo that this is the dilatation of aorta and loss of fibril, and this is deep. The mice, those who were on losartan, the aorta is almost similar to placebo. So they were very excited that we found some magic drug, and they tried it on infants. And what happened was there was no statistically significant difference between losartan and beta blocker. What went wrong was they chose to give a very small dose of losartan, considering a concern that losartan in a younger children can cause a reduction in the height because of their effect on chondroitin. So that is why we are in kind of a fix, but we do have recent trials which say that on a meta-analysis that we can use losartan to prevent dilatation of aorta. Now, Bental was the person, this was a case report what he made in this journal, and which actually revolutionized the entire way of treating patients with dilated aorta. This is prophylactic change of aorta and not doing a replacement of aorta once the person develops a dissection, because then many patients are lost even before surgery, and very high mortality in case you entertain the changing of aorta while the dissection has already happened. So preventing dissection was the preventive change of aorta, and what technique what we call as a Bental, where there is a valve plus the conduit which is put on the aorta. We remove the aortic valve, which remove the ascending part of the aorta, and this is what we call as a Bental surgery. Went well, and still we have a modified Bental surgery, and we went with the aortic valve replacement, and many patients did not have aortic regurgitation, or there was no indication of replacing aortic valve. So unnecessarily we were giving prosthetic aortic valve, and now we have techniques of valve sparing aortic root surgeries as a preventive for dissection of aorta. I hope I made things simple. I mean, I don't think so really a bad idea to subscribe the channel and keep waiting for my next videos. I'm not going to stop it. I'm going to continue this education journey for you guys, and happy learning. That's what I can say.